Hello, future nurses and NCLEX champions. Welcome once again to Stancoast NCLEX, where learning meets confidence and success. We post 2 to 3 advanced NCLEX videos every single day, designed to simplify complex concepts, sharpen your clinical reasoning, and prepare you to think like a professional nurse. In today's gastrointestinal focused session, we are exploring a vital and frequently tested topic: nursing care of clients with disorders of the stomach. The stomach plays a key role in digestion, and any disorder here can have wide-ranging effects on nutrition and overall health. In this session, we will discuss conditions such as gastritis, peptic ulcer disease, gastroenteritis, and gastric cancer. You will learn the underlying pathophysiology, hallmark signs and symptoms like epigastric pain and hematemesis, diagnostic procedures including endoscopy and stool occult blood testing, and priority nursing interventions. We will also review dietary modifications, medication management such as proton pump inhibitors and antacids, and nursing care before and after procedures like gastrectomy. So stay tuned, take notes, and engage actively, because this topic connects anatomy, pathophysiology, and nursing care in a way that's essential for both the NCLEX and real-world practice. And remember,
if your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get: 100-hour mini crash course perfect for those who want to pass within a week, 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested, 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
moving forward, let us examine our advanced level NCLEX scenario centered on gastrointestinal assessment and symptom correlation. A 46-year-old client is admitted for evaluation of recurrent, gnawing epigastric pain that tends to occur several hours after meals. The nurse suspects a peptic ulcer and begins a detailed history. Based on this suspected condition, the nurse would expect the client to report that the epigastric pain decreases after which activity. Here are the possible options. Option A suggests skipping meals, Option B recommends going to bed, Option C states eating food, and Option D proposes vomiting. The correct answer is Option C, eating food. Now, diving deeper into the expanded rationale, let us explore the physiological reasoning behind this finding. Peptic ulcers develop when the protective mucosal barrier of the stomach or duodenum is breached, allowing hydrochloric acid and pepsin to erode underlying tissues. This erosion leads to a burning or gnawing epigastric pain typically located between the xiphoid process and the umbilicus. In gastric ulcers, pain tends to occur within 30 to 60 minutes after meals because food stimulates acid production, worsening irritation of the stomach's already inflamed lining. However, in duodenal ulcers, which are more common, pain usually develops 2 to 3 hours after eating and is actually relieved by food or antacids. This occurs because food temporarily buffers the acid, raises the gastric pH, and coats the mucosa, reducing the intensity of irritation. In contrast, skipping meals, as in Option A, increases discomfort because acid continues to accumulate in the stomach without neutralization. Similarly, Option B, going to bed, often exacerbates symptoms since lying flat allows acid reflux to reach the ulcer site, frequently causing clients to awaken at night with burning pain. Meanwhile, Option D, vomiting, might momentarily empty the stomach but fails to decrease acid secretion and can instead worsen dehydration, electrolyte imbalance, and mucosal injury. Thus, the nurse correctly expects the client to report that eating food decreases pain, a hallmark feature of duodenal ulcers. This distinction between duodenal and gastric ulcer patterns helps guide clinical assessment and targeted management. Transitioning to the Stancoast clinical insight, remember this golden observation. Peptic ulcer pain tells a story of acid and timing. If food brings comfort, think duodenum. If food brings agony, think stomach. Recognizing this subtle difference enables nurses to anticipate complications early and support accurate diagnosis. And now, leading into our Stancoast high-yield NCLEX Pearl, Duodenal ulcer pain typically decreases after meals, while gastric ulcer pain worsens postprandially. Nocturnal pain that awakens the client is characteristic of duodenal ulcers. Both food and antacids can offer temporary relief by buffering acid, but persistent or severe pain requires prompt medical evaluation to prevent bleeding, perforation, or obstruction. Let us now transition into this next advanced level NCLEX-style question that sharpens both your diagnostic reasoning and clinical correlation skills. A 48-year-old client is admitted with complaints of burning epigastric pain, nausea, and occasional black, tarry stools. The nurse suspects peptic ulcer disease. In addition to the client's symptoms, which positive laboratory finding provides further evidence supporting this diagnosis? The options are as follows. Option 1 suggests urine that is positive for albumin. Option 2 indicates blood that is positive for glucose. Option 3 states stool that is positive for blood. And option 4 mentions emesis that is positive for pepsin. The correct answer is option 3, stool that is positive for blood. Now, taking a closer look at the expanded advanced rationale, it is essential to understand why this finding matters so profoundly. In peptic ulcer disease, ulceration erodes the protective mucosal barrier of the stomach or duodenum, damaging underlying blood vessels and leading to gastrointestinal bleeding. This bleeding manifests as melena, which is black, tarry stool caused by the breakdown of hemoglobin by intestinal bacteria. Even when melena is not visibly apparent, a fecal occult blood test can detect microscopic bleeding. This positive finding, when paired with the client's clinical symptoms of epigastric pain and nausea, provides strong supporting evidence for peptic ulcer disease. Persistent occult bleeding also contributes to iron deficiency anemia, alerting the healthcare team to potential chronic blood loss. Therefore, identifying blood in the stool not only aids diagnosis but also signals the urgency for endoscopic confirmation and therapeutic intervention to prevent hemorrhage or perforation. Turning now to the incorrect options, let us analyze why they do not align with the pathophysiology of peptic ulcer disease. To begin with, option 1, urine positive for albumin, reflects renal glomerular injury, typically seen in nephrotic syndrome, hypertension, or diabetic nephropathy. Since the kidneys are unrelated to the gastric mucosa, this finding holds no diagnostic value for ulcers. Next, option 2, blood positive for glucose, indicates glycosuria, which occurs when blood glucose levels exceed the renal threshold, as seen in diabetes mellitus. Although stress can transiently elevate glucose, it does not suggest mucosal erosion or bleeding. Moving forward, option 4, emesis positive for pepsin, lacks diagnostic significance because pepsin is a normal digestive enzyme present in gastric contents. However, if the emesis appears coffee ground, that would suggest partially digested blood from upper gastrointestinal bleeding, which is clinically meaningful in ulcer disease. And as we connect this discussion to deeper clinical understanding, here comes your Stancoast clinical insight. Every drop of hidden blood in the stool tells the silent story of a bleeding ulcer. Recognizing this subtle evidence transforms a simple laboratory test into a life-saving diagnostic clue. Finally, to cement this concept in your memory, let us wrap up with the Stancoast high-yield NCLEX pearl. Melena refers to black tarry stool, a classic sign of an upper gastrointestinal bleed. Occult blood denotes microscopic bleeding and serves as early evidence of mucosal injury. Always correlate these findings with hemoglobin, hematocrit, and vital signs. Quick recognition and prompt reporting can prevent hemorrhagic shock due to unnoticed gastrointestinal bleeding. Let us begin this next captivating NCLEX-style question that strengthens your grasp of diagnostic imaging and client education in gastrointestinal care. A client is scheduled for an X-ray of the upper gastrointestinal tract. After the nurse explains the procedure, which statement by the client best demonstrates an accurate understanding of what this diagnostic test involves? Here are the options. Option 1 says, a flexible tube will be inserted into my stomach. Option 2 states, dye will be infused into my vein before the test. Option 3 mentions, my body will be placed within an imaging chamber. And option 4 explains, I will have to swallow a large amount of barium. The correct answer is option 4, I will have to swallow a large amount of barium. Now moving into the detailed advanced rationale, an upper gastrointestinal series, also known as a barium swallow, is a fluoroscopic X-ray procedure that visualizes the esophagus, stomach, and duodenum. During this test, the client drinks barium sulfate, a thick, chalky, radiopaque substance that coats the inner lining of the gastrointestinal tract. Because barium absorbs X-rays, it outlines the shape and contour of the digestive organs, helping identify ulcers, strictures, tumors, hiatal hernias, and motility abnormalities. Therefore, the client's statement about swallowing barium clearly shows an accurate understanding of what the procedure entails. Before the test, the client must remain nothing by mouth for 6 to 8 hours to keep the stomach empty and minimize the risk of aspiration. All metallic objects should be removed to avoid interference with imaging quality. After the procedure, the nurse encourages the client to drink plenty of fluids and may recommend a mild laxative to promote barium elimination from the intestines. The client should also be informed that stools may appear white or clay-colored for 1 to 3 days, a normal and temporary effect of the test. Furthermore, let us understand why the other options are incorrect. Option 1, a flexible tube will be inserted into my stomach, actually describes an esophago-gastroduodenoscopy, EGD, which uses a flexible scope to directly view the gastrointestinal tract rather than using X-rays. Option 2, dye will be infused into my vein before the test, corresponds to procedures such as an intravenous pyelogram or CT scan with intravenous contrast, not a barium swallow, since the contrast here is swallowed, not injected. Option 3, my body will be placed within an imaging chamber, refers to a magnetic resonance imaging, MRI, procedure, which uses magnetic fields and does not involve barium ingestion. Transitioning now to our clinical reflection, let us focus on the essential takeaway. Barium swallow studies transform the invisible movement of digestion into visible structure and motion. A nurse's clear explanation and preparation help ensure patient safety, cooperation, and diagnostic accuracy. Transitioning further into exam mastery, Stancoast, high-yield NCLEX Pearl, always keep the client nothing by mouth for 6 to 8 hours before the procedure. Encourage increased fluid intake and the use of mild laxatives afterward to help remove barium from the intestines. Expect stools to appear temporarily white or chalky for 1 to 3 days after the test. Lastly, observe for constipation or abdominal discomfort, which may signal retained barium requiring medical attention. Let us smoothly transition into this next advanced level NCLEX-style question that sharpens your pharmacology, dosage calculation, and clinical reasoning skills all at once. The scenario goes like this. A client is diagnosed with a duodenal ulcer, and the healthcare provider prescribes a triple therapy regimen consisting of clarithromycin, metronidazole, and omeprazole. Specifically, the orders are clarithromycin, Biaxin, 500 milligrams 3 times daily, metronidazole, Flegel, 250 milligrams 4 times daily, and omeprazole, Prilosec, 40 milligrams twice daily. Based on these prescriptions, the nurse must determine the total number of milligrams the client will receive in 24 hours for all 3 medications combined. After carefully computing, the correct answer is 2,580 milligrams per day. Now, let us thoughtfully explore the expanded advanced rationale behind this answer. This question not only checks mathematical accuracy, but also tests your understanding of Helicobacter pylori, H. pylori, eradication therapy, the cornerstone of duodenal ulcer management. Triple therapy combines 2 antibiotics with a proton pump inhibitor to attack the infection from multiple angles, eliminate bacteria, suppress acid production, and promote mucosal healing. First, let us perform the calculation step by step. Clarithromycin at 500 milligrams taken 3 times daily equals 1,500 milligrams per day. Metronidazole at 250 milligrams 4 times daily adds 1,000 milligrams per day. Lastly, omeprazole at 40 milligrams twice daily contributes 80 milligrams per day. When we sum all 3, 1,500 plus 1,000 plus 80, the total equals 2,580 milligrams per day. From a pharmacologic perspective, clarithromycin is a macrolide antibiotic that inhibits bacterial protein synthesis by binding to the 50S ribosomal subunit, stopping bacterial replication. Metronidazole, an antiprotozoal and antibacterial agent, interferes with DNA synthesis in anaerobic organisms, forming cytotoxic intermediates that disrupt DNA strands. Omeprazole, a proton pump inhibitor, irreversibly blocks hydrogen-potassium ATPase pumps in gastric parietal cells, effectively reducing gastric acid secretion. This suppression creates an environment that allows antibiotics to act more effectively while enabling the mucosa to heal. Together, this regimen produces a synergistic effect. Antibiotics eradicate the H. pylori infection, while omeprazole maintains an elevated gastric pH, reducing irritation and promoting ulcer repair. From a nursing standpoint, accurate dose calculation ensures therapeutic safety and prevents under- or overdosing. Nurses must confirm the correct frequency and total daily intake. Monitor for side effects such as nausea, diarrhea, or a metallic taste from metronidazole, and teach the client to complete the entire course of therapy even if symptoms subside early. This adherence prevents antibiotic resistance and recurrence. Additionally, clients should be educated to avoid alcohol while on metronidazole to prevent a disulfiram-like reaction characterized by flushing, vomiting, and tachycardia. Transitioning now to a key reflective takeaway, Stancoast Clinical Insight. Triple therapy for duodenal ulcers targets both cause and cure, eradicating H. pylori while fostering mucosal healing. Precision in calculation and timing ensures each drug reinforces the others, creating the perfect triad for successful ulcer resolution. And finally, as we conclude with a crucial exam-focused reminder, Stancoast High-Yield NCLEX Pearl. Always remember, H. pylori equals 2 antibiotics plus 1 proton pump inhibitor. Verify every dosage and schedule carefully. Instruct clients to avoid alcohol during therapy, adhere strictly to the regimen, and report any adverse gastrointestinal symptoms promptly. Let us now move forward into our next engaging clinical scenario that explores the reasoning behind ulcer therapy and antibiotic use. A client diagnosed with a peptic ulcer asks the nurse, "Why has my physician prescribed antibiotics for an ulcer? I thought ulcers were caused by acid." The nurse must respond with an evidence-based explanation that best clarifies the rationale for antibiotic therapy in peptic ulcer disease. Here are the options to consider carefully. Option A suggests that antibiotics heal the irritated mucous membrane of the stomach. Option B states that antibiotics eliminate a microorganism that depletes gastric mucus. Option C mentions that antibiotics add a protective coating over the ulcerated mucosa. Option D explains that antibiotics prevent secondary gastrointestinal infections. The correct answer is Option 2. Antibiotics eliminate a microorganism that depletes gastric mucus. Now, let us examine the expanded advanced rationale behind this important concept. This question focuses on the nurse's understanding of Helicobacter pylori, H. pylori, associated peptic ulcer disease, and the scientific basis for antibiotic therapy. In most clients, H. pylori infection is the root cause of both gastric and duodenal ulcers. This bacterium colonizes the gastric mucosa and produces the enzyme urease, which converts urea into ammonia. The ammonia neutralizes stomach acid locally, but simultaneously damages the protective mucosal barrier. As a result, hydrogen ions and pepsin penetrate the mucosal lining, leading to chronic inflammation, erosion, and eventual ulcer formation. Antibiotics such as clarithromycin, Biaxin, amoxicillin, or metronidazole, Flagyl, are prescribed to eradicate H. pylori, addressing the underlying cause rather than simply managing symptoms. When combined with a proton pump inhibitor, PPI, like omeprazole, Prilosec, or lansoprazole, Prevacid, this creates what is known as triple therapy, which reduces gastric acid secretion while eliminating the bacterial infection. This dual action promotes complete mucosal healing and prevents recurrence. On the other hand, option 1 is incorrect because antibiotics do not directly repair mucosal tissue. Healing occurs naturally once the infectious cause is eliminated and acid production is reduced. Option 3 is inaccurate since antibiotics have no coating or protective property. This effect is provided by medications such as sucralfate, carafate, or bismuth subsalicylate, Pepto-Bismol. Finally, option 4 is wrong because antibiotics are not given to prevent other gastrointestinal infections. Their purpose is strictly to eradicate H. pylori. Transitioning now to deeper understanding, here comes your Stancoast clinical insight. Modern ulcer therapy is not merely about acid suppression, it is about pathogen elimination. Eradicating H. pylori removes the root cause, restores the protective gastric barrier, and prevents ulcer recurrence. And to reinforce your memory, here is the Stancoast High-Yield Pearl. Always remember the triple therapy rule for H. pylori. 2 antibiotics plus 1 PPI. Commonly used combinations include clarithromycin with amoxicillin and omeprazole, or metronidazole if the client is allergic to penicillin. Reinforce adherence by instructing the client to complete the full antibiotic course to prevent resistance. Advise avoidance of alcohol when taking metronidazole to prevent a disulfiram-like reaction. Finally, confirm bacterial eradication through a urea breath test or stool antigen test 4 weeks after completing therapy. Hold on just a second, because your NCLEX breakthrough could start right here.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Let us now transition into our next clinically focused NCLEX-style question that emphasizes client education and medication safety during discharge teaching. A client recovering from a peptic ulcer is getting ready to go home, and the licensed practical nurse collaborates with the team leader to reinforce essential self-care instructions aimed at preventing further gastrointestinal irritation and recurrence of ulcer symptoms. During this teaching session, the nurse explains the importance of selecting safe medications for occasional pain or discomfort. So, which medication should the nurse recommend as the safest option for relieving mild pain based on the client's medical history of peptic ulcer disease? Here are the options to consider carefully. Acetaminophen, also known as Tylenol. Aspirin, commonly recognized by the brand Anacin. Ibuprofen, marketed as Advil. And naproxen, available as naproxen. The correct answer is option 1, acetaminophen or Tylenol. Now, moving on to the detailed rationale that strengthens this concept. Acetaminophen is the preferred analgesic for clients with a history of peptic ulcer disease because it poses minimal gastrointestinal toxicity and does not interfere with prostaglandin synthesis within the gastric mucosa. Prostaglandins play a vital role in preserving mucosal integrity by promoting mucus and bicarbonate secretion, maintaining sufficient mucosal blood flow, and protecting the epithelial lining from acid-induced injury. Unlike nonsteroidal anti-inflammatory drugs, or NSAIDs, acetaminophen acts centrally on the brain to reduce pain and fever without affecting the protective gastric mechanisms. This makes it highly suitable for pain relief in ulcer clients, as it does not contribute to gastrointestinal bleeding or irritation. On the contrary, aspirin must be avoided because it irreversibly inhibits cyclooxygenase enzymes, thereby decreasing prostaglandin production and compromising the stomach's protective barrier, leading to potential ulcer exacerbation or bleeding. Similarly, ibuprofen inhibits prostaglandin synthesis, which can result in gastritis, ulcer recurrence, and even hidden internal bleeding, even after short-term use. Naproxen, being a longer-acting NSAID, further increases acid secretion and delays the healing of existing ulcers, making it unsafe for such clients. Transitioning to a deeper clinical reflection, Stancoast. Clinical insight reminds us that pain relief should never come at the cost of mucosal safety. In ulcer management, the golden rule is protect first, relieve next. Acetaminophen safeguards the stomach while easing discomfort, making it the analgesic of choice for ulcer clients. And to conclude with a high-yield takeaway, Stancoast High-Yield Pearl highlights an easy memory cue. A for acetaminophen equals A for acid safe. Always remember to avoid all NSAIDs and salicylates in ulcer patients. Use the lowest effective dose of Tylenol. And educate clients to carefully check all over-the-counter medication labels for hidden NSAIDs. If pain persists or digestive discomfort returns, it is essential that clients seek medical reassessment rather than self-medicating. Let us move forward to another high-stakes NCLEX-style clinical scenario that sharpens your assessment and critical thinking skills. A nurse is performing a detailed head-to-toe examination, on a client with a known history of recurrent peptic ulcer disease who is currently being prepared for abdominal surgery. Suddenly, the client complains of sharp, severe epigastric pain radiating to the shoulder, accompanied by nausea and noticeable abdominal distension. At this moment, the nurse must interpret which physical assessment finding would most strongly suggest that the ulcer has perforated. Here are the options to evaluate carefully. Option A states that the client's skin appears ecchymotic. Option B describes the client's abdomen as board-like and rigid. Option C notes that the client's pupils are widely dilated. Option D reports that the client's respirations are rapid and shallow. The correct answer is Option B. The client's abdomen feels board-like and rigid. Now, let us dive into the detailed rationale behind this critical observation. Perforation of a peptic ulcer represents a life-threatening surgical emergency caused by erosion through the full thickness of the gastric or duodenal wall, allowing gastric or intestinal contents to leak into the sterile peritoneal cavity. This spillage triggers chemical peritonitis first, followed by bacterial infection that can progress rapidly to septic shock if not managed promptly. The most defining clinical feature is a board-like, rigid abdomen, a result of involuntary muscular guarding provoked by severe peritoneal irritation. The pain is abrupt, excruciating, and persistent, often radiating to the shoulder due to diaphragmatic irritation from gastric acid and bile. Additional findings include absent bowel sounds, tachycardia, hypotension, and shallow respirations caused by intense pain and evolving circulatory collapse. At this point, the nurse's immediate priorities become clear. Keep the client nil per OS to prevent further leakage, insert a nasogastric tube for decompression, establish large-bore intravenous access for aggressive fluid resuscitation, administer broad-spectrum antibiotics as prescribed, and notify the surgeon without delay for emergency surgical intervention. Next, let us analyze why the other options do not fit this clinical picture. To begin, Option A, the client's skin appears ecchymotic, is incorrect because bruising is not a hallmark of ulcer perforation. Ecchymosis may suggest retroperitoneal bleeding or acute pancreatitis. But in perforation, pallor arises from vasoconstriction and decreased perfusion linked to hypovolemic shock rather than discoloration of the skin. Moving on, Option C, the client's pupils are widely dilated, is also incorrect. Pupil dilation can occur due to stress, medication effects, or neurological disorders, none of which directly relate to gastrointestinal perforation. Hence, it has no diagnostic value in this case. Finally, Option D, the client's respirations are rapid and shallow, is incorrect because although tachypnea often accompanies pain or developing shock, it remains a nonspecific response. The rigid, board-like abdomen is the most reliable indicator of peritonitis resulting from perforation. Transitioning into our clinical reflection, Stancoast Clinical Insight. When a client with a history of peptic ulcer disease suddenly reports unbearable pain followed by a rock-hard abdomen, every second counts. That rigidity signals the peritoneum's cry for help, a classic alarm of perforation. Rapid recognition and immediate action can make the difference between life and loss. Moving ahead to the memory key for exam success, Stancoast High Yield NCLEX Pearl. Board-like rigidity equals peritonitis from ulcer perforation. Sudden, severe pain with shoulder radiation equals diaphragmatic irritation. Priority nursing sequence. Keep the client NPO. Insert nasogastric tube. Begin intravenous fluids. Notify surgeon immediately. Remember, in ulcer perforation, mortality results from peritonitis, not from pain. Act fast and save life. To kick off this advanced clinical scenario, let us explore a question that evaluates both technical skill and anatomical precision. During the insertion of a nasogastric tube for a client diagnosed with a perforated ulcer, the licensed practical nurse assists the registered nurse in determining the appropriate length of tubing to be inserted. The nurse must ensure that the tube reaches the stomach safely without entering the respiratory tract. So, to achieve accurate placement, the nurse correctly places the tip of the tube at the client's nose and measures the distance from there to which anatomical landmarks. Here are the options to consider carefully. Option 1 suggests measuring from the nose to the jaw and then midway to the sternum. Option 2 advises measuring from the nose to the mouth and then between the nipples. Option 3 proposes measuring from the nose to the mid-sternum and then to the umbilicus. Option 4 indicates measuring from the nose to the ear and then to the xiphoid process. The correct answer is option 4, from the nose to the ear, and then to the xiphoid process. Now, transitioning to the expanded rationale, let us understand why this measurement is vital. Determining the correct insertion length is not merely procedural. It is a life-saving safety measure. An incorrectly measured tube may coil in the esophagus, cause aspiration, or fail to reach the stomach. The most accurate and clinically validated technique is called the NEX method, representing the landmarks nose, earlobe, xiphoid. The nurse begins by placing the tip of the tube at the client's nose, extends it to the earlobe, and continues down to the xiphoid process, the lower end of the sternum. This pathway mirrors the natural anatomical course of the nasopharynx, oropharynx, and esophagus, providing the best approximation of the distance to the stomach. Furthermore, it is essential to emphasize that after measuring and inserting the tube to this calculated depth, verification of placement must always be performed before administering anything through it. The gold standard method remains an X-ray confirmation, though bedside methods such as aspirating gastric contents and checking for a pH less than 5 can offer additional clues to gastric placement. In contrast, all other options listed are anatomically inaccurate. Measuring only to the jaw or sternum would leave the tube short, possibly in the esophagus, posing a risk for regurgitation and aspiration. Measuring toward the umbilicus or nipples has no clinical relevance to the upper gastrointestinal tract and could result in over or under insertion. Therefore, option 4, nose to earlobe to xiphoid, stands as the only correct and safe choice supported by evidence-based practice. Transitioning to our Stancoast clinical insight. Precision in measurement ensures precision in care. The next method transforms a routine nursing task into a critical act of patient safety, anchoring the nasogastric tube exactly where nutrition and decompression are intended, not where complications begin. And now, moving on to the Stancoast High-Yield NCLEX Pearl, always remember to measure nose-earlobe xiphoid, NX, before insertion. Verify placement by X-ray before any feeding or medication. Clearly mark and document the insertion length to detect migration, and never rely solely on auscultation for placement confirmation, as it is unreliable and unsafe. Let us smoothly transition into this next clinical question that focuses on communication during a critical nursing procedure. As the nasogastric tube passes through the client's nasal cavity and reaches the oropharynx, the nurse must provide exact instructions to ensure that the tube moves safely into the esophagus rather than the airway. So, which instruction should the nurse give the client at this stage? Here are the options to consider carefully. Option 1 suggests, breathe deeply as the tube is advanced. Option 2 advises, hold your head in a sniffing position. Option 3 instructs, press your chin to your upper chest. Option 4 directs, avoid coughing until the tube is down. The correct answer is option 3, press your chin to your upper chest. When the nasogastric tube reaches the oropharynx, the risk of misdirection into the trachea rises sharply. By instructing the client to press the chin toward the chest, the nurse effectively closes the epiglottis and aligns the pharyngeal pathway toward the esophagus, steering the tube away from the airway and preventing accidental tracheal insertion. This chin tuck position shortens the anatomical pathway from the nasopharynx to the esophagus, making tube advancement smoother and much safer. Furthermore, the nurse often offers sips of water, if permitted, to stimulate swallowing. Swallowing naturally closes the epiglottis and opens the upper esophageal sphincter, guiding the tube correctly toward the stomach. Encouraging small swallows while keeping the chin tucked ensures precise passage and minimizes complications. In contrast, option 1, asking the client to breathe deeply, is incorrect because deep breathing can pull the tube toward the airway and increase the risk of aspiration. Option 2, the sniffing position, is useful only during the initial insertion phase to align the nasopharyngeal route but becomes unsafe once the tube reaches the oropharynx since it opens the airway. Finally, option 4, advising the client to avoid coughing, is inappropriate because coughing is a protective reflex that signals the tube may have entered the trachea. The nurse should never suppress this reflex. Instead, the procedure should be stopped immediately if coughing or respiratory distress occurs. By using the chin-to-chest technique, the nurse ensures that anatomical alignment directs the tube into the esophagus, thereby maintaining airway safety and preventing serious complications such as aspiration pneumonia, laryngospasm, or bronchial misplacement. Transitioning to a Stancoast clinical insight. Nasogastric tube insertion is a delicate dance between precision and protection. The chin-to-chest maneuver transforms anatomy into safety, ensuring the pathway leads directly to the stomach, not the lungs. Moving on to the Stancoast High-Yield NCLEX Pearl. Chin-to-chest equals directs tube safely into the esophagus. Sniffing position equals used only for the initial nasal entry. Stop immediately if coughing, choking, or cyanosis occurs. Always verify tube placement by aspirating gastric contents and confirming pH or through an X-ray before administering any feeding or medication. Moving forward, let us now explore a procedural question that tests your understanding of nursing precision during nasogastric tube insertion, a skill that demands both accuracy and patient cooperation. The nurse is preparing to insert a nasogastric tube into an adult client for gastric decompression. The question asks you to arrange the following nursing actions in the correct order of performance using all options. Here are the options to consider carefully. Option 1. Instruct the client to sip water as the tube is inserted. Option 2. Aspirate fluid from the stomach. Option 3. Have the client lower the chin. Option 4. Inspect the nares to determine which should be used. Option 5. Secure the nasogastric tube to the nose. Option 6. Ask the client to tilt the neck to simulate a sniffing position. The correct order is Option 4, followed by Option 6, Option 3, Option 1, Option 2, and finally, Option 5. Now let us walk through the expanded clinical rationale step by step. The nasogastric tube insertion process follows a specific, evidence-based sequence designed to minimize trauma and prevent aspiration. First, the nurse must inspect the nares to determine which side is more patent, free of obstruction or deviation. Selecting the clearer nare ensures easier insertion and less discomfort. Next, the nurse should ask the client to tilt the neck slightly backward into a sniffing position, which aligns the nasal and pharyngeal passages for smooth passage of the tube through the nasopharynx without friction or mucosal injury. Once the tube reaches the oropharynx, the nurse instructs the client to lower the chin toward the chest, which closes off the trachea and redirects the tube toward the esophagus. This is a critical step to prevent accidental entry into the airway. After that, the nurse should instruct the client to sip water while advancing the tube, as swallowing naturally opens the esophagus and facilitates easier passage into the stomach. Once placement appears correct, the nurse should aspirate gastric contents to confirm entry into the stomach. Gastric aspirate typically has an acidic pH less than or equal to 5, verifying accurate placement. Finally, the nurse must secure the tube to the nose using adhesive tape or a specialized holder to prevent displacement and ensure ongoing safety and effectiveness. Transitioning now to a key insight, Stancoast. Clinical insight. Verification of nasogastric tube placement must always occur before administering medications, feedings, or connecting suction. The safest nursing practice includes checking placement through multiple methods, pH testing, external length measurement, and when prescribed, radiographic confirmation. Remember, verification saves lives. And before we wrap up Stancoast High-Yield NCLEX Pearl, an easy memory cue to retain the entire sequence is inspect, align, flex, swallow, verify, secure. This simple 6-step pathway mirrors the anatomical journey from nose to stomach, ensuring that every insertion you perform is safe, accurate, and client-centered. Let us now move to an essential and frequently tested clinical scenario in the NCLEX that focuses on precision in gastric decompression technique. A nurse is preparing to connect a client's single-lumen nasogastric tube to suction before abdominal surgery for intestinal obstruction. The question asks, which suction setting should the nurse select to ensure effective decompression while minimizing mucosal injury? Here are the options to analyze carefully. Option 1, low intermittent suction. Option 2, low continuous suction. Option 3, high intermittent suction. Option 4, high continuous suction. The correct answer is Option 1, low intermittent suction. Now let us explore the expanded clinical rationale behind this answer. The most appropriate setting for a single-lumen nasogastric tube is low intermittent suction because it effectively removes gastric contents and air while protecting the stomach lining from trauma. In this method, suction alternates between gentle negative pressure and rest periods, allowing gastric mucosa to decompress safely without adhering to the tube. Typically, the suction pressure is maintained between 40 and 60 millimeters of mercury, which ensures adequate decompression while preventing tissue damage. On the other hand, Option 2, low continuous suction, should never be used with a single lumen tube. Continuous suction may cause the tube tip to adhere to the gastric wall, leading to ischemia, bleeding, or even ulceration. This setting is appropriate only for double lumen or vented tubes, such as the Salem sump, which contains an air vent that equalizes internal pressure. Meanwhile, option 3, high intermittent suction, might seem effective for faster drainage, but the strong suction pressure can result in excessive electrolyte and fluid loss, leading to irritation of the gastric mucosa. Likewise, option 4, high continuous suction, poses the greatest danger since it delivers constant high pressure that severely injures gastric tissue and causes rapid depletion of gastric secretions, predisposing the client to metabolic alkalosis due to loss of hydrochloric acid. Hence, option 1, low intermittent suction, is the safest and most evidence-based nursing practice when managing single-lumen nasogastric tubes, providing both efficient decompression and mucosal safety. Transitioning now to your Stancoast clinical insight. Intermittent suction gives the stomach time to breathe, balancing effective decompression with mucosal protection. Every correct suction setting demonstrates a nurse's precision in promoting healing while preventing harm. Moving forward to the Stancoast high-yield NCLEX Pearl, always remember, a single lumen Levin tube requires low intermittent suction, while a double lumen Salem sump tube can safely use low continuous suction. Maintain suction pressure between 40 and 60 millimeters of mercury. Check tubing patency regularly and assess the color and consistency of drainage. If suction output suddenly stops, always check for kinks or blockages before adjusting the pressure. Moving forward to another essential and often tested NCLEX clinical situation that focuses on airway protection during nursing procedures, imagine this. A nurse is inserting a nasogastric tube when the client suddenly turns blue and begins to cough vigorously. The question asks, which additional sign indicates that the tube has mistakenly entered the respiratory tract? Let us carefully examine the options. Option 1, inability to speak. Option 2, inability to swallow. Option 3, sneezing. Option 4, vomiting. The correct answer is option 1, inability to speak. To understand why, let us dive into the detailed clinical rationale. During nasogastric tube insertion, ensuring a patent airway and adequate oxygenation is the nurse's top priority. If a client becomes cyanotic and coughs forcefully, it suggests that the tube has been accidentally inserted into the respiratory tract. The most definitive sign of this misplacement is the inability to speak. When the tube passes through the larynx and between the vocal cords, it blocks the airflow necessary for vibration, making speech impossible. This occurs because the vocal cords cannot function when obstructed by the tube. In such a case, the nurse must act immediately, withdraw the tube back to the oropharynx to clear the airway, and allow the client to breathe normally. Once the client stabilizes, reinsertion can be attempted safely, ensuring that the client swallows during advancement to guide the tube correctly into the esophagus. Correct placement should always be verified by aspirating gastric contents and checking for a pH of 5 or less, or confirming position via X-ray before initiating suction or feeding. Meanwhile, option 2, inability to swallow, is incorrect because swallowing primarily involves the oropharyngeal and esophageal muscles, which can still function even if the tube has entered the airway. Option 3, sneezing, simply results from nasal irritation during insertion and is not an indicator of tube misplacement. Option 4, vomiting, is caused by gastric or esophageal irritation, but does not confirm entry into the trachea. Now, transitioning into the Stancoast clinical insight, airway safety is a nurse's highest responsibility. When a client suddenly becomes unable to speak during nasogastric tube insertion, the body is signaling distress. A silent cry for help, immediate tube withdrawal, and airway reassessment can make the difference between safety and catastrophe. And to conclude with the Stancoast high-yield NCLEX Pearl, stop the procedure at once if coughing, choking, or cyanosis occurs. Inability to speak is a clear indicator of tracheal entry. Withdraw immediately. Always confirm placement with pH testing or X-ray before suctioning or feeding, and never rely on air insufflation as it is unreliable and unsafe. Let us now move forward to another vital and safety-focused NCLEX question that tests your understanding of enteral feeding verification procedures. The nurse is preparing to administer a feeding through a nasogastric tube that has just been inserted. The question asks, which is the most appropriate technique for determining whether the distal end of the nasogastric tube is correctly positioned in the stomach? Here are the options. The first option suggests requesting a portable X-ray of the stomach. The second option proposes listening over the stomach while instilling air into the tube. The third option recommends adding 100 milliliters of tap water into the tube to assess tolerance. And finally, the fourth option mentions feeling for air movement at the proximal end of the tube. The correct answer is option 1, requesting a portable X-ray of the stomach. Now, let us explore the expanded advanced rationale to understand why this is the safest and most evidence-based approach. Accurate placement verification of a nasogastric tube is a critical nursing responsibility that safeguards against life-threatening complications such as pulmonary aspiration, pneumonia, or gastric perforation. Among all available techniques, radiographic confirmation, or X-ray, remains the gold standard for verifying the tube's correct position. An X-ray allows direct visualization of the tube's distal tip, confirming that it lies below the diaphragm and within the stomach, rather than in the esophagus or respiratory tract. This verification is mandatory before initiating the first feeding or administering any medication through the tube. On the other hand, option 2, listening for a whooshing sound over the stomach while instilling air, is a traditional method that has been deemed unreliable in modern nursing practice. Although it may produce audible sounds, similar noises can also be heard if the tube is accidentally placed in the lungs or esophagus, leading to false reassurance and dangerous consequences, such as aspiration. Therefore, this method is now considered outdated and unsafe. Continuing on, option 3, adding 100 milliliters of tap water into the tube poses a significant risk and should never be performed before confirming tube placement radiographically. Instilling fluid before placement verification can result in water entering the lungs if the tube is misplaced, particularly in unconscious or ventilated patients. Furthermore, tap water is non-sterile and unsuitable for direct gastrointestinal use in vulnerable individuals, increasing the risk of infection. Moving to option 4, feeling for air at the proximal end of the tube, this method lacks any scientific validity or clinical reliability. It provides neither visual nor acoustic confirmation and cannot be used as a determinant of correct tube position. In addition to radiographic confirmation, nurses may employ secondary bedside techniques, such as aspirating gastric contents and testing their pH. Normally, gastric aspirate has a pH between 1 and 5, indicating the presence of acidic gastric fluid. However, in patients receiving proton pump inhibitors or continuous tube feeding, the gastric environment may become less acidic, which limits the reliability of pH testing alone. Importantly, before each subsequent use of the nasogastric tube following the initial X-ray verification, the nurse should reconfirm placement by rechecking the tube's external length and aspirating gastric contents for pH testing. These practices ensure ongoing safety and early detection of accidental tube migration. Transitioning to the Stancoast clinical insight. Before we conclude, let us highlight a crucial clinical takeaway. Never rely on sound, guesswork, or assumption when verifying nasogastric tube placement. Always prioritize radiographic validation. Because in enteral feeding, precision is the ultimate safeguard against aspiration, pneumonia, and other complications. And now, leading into our Stancoast high-yield NCLEX Pearl. Remember, X-ray confirmation is the gold standard for verifying nasogastric tube placement before its first use. Never instill liquids or feedings until placement is confirmed. Air auscultation is outdated and unreliable. Always check aspirate pH and tube length before each subsequent feeding. In short, safety verification is the nurse's strongest defense against aspiration and respiratory compromise.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Let us transition into this next emotional and ethically grounded NCLEX-style scenario that tests your ability to apply therapeutic communication in a life-threatening situation. Imagine a client with a perforated peptic ulcer who has just been rushed to the emergency department for emergency surgery. The client appears pale, anxious, and frightened. While holding the nurse's hand, the client trembles and asks, "Am I going to die?" The question challenges the nurse's compassion, professionalism, and communication skills under pressure. Here are the options. Option 1 says, "We are doing everything we can right now to help you." Option 2 responds, "That is something you will have to ask your physician." Option 3 states, "Now what kind of a silly question is that?" Option 4 answers, "I've seen patients with similar problems pull through." The correct answer is Option 1, "We are doing everything we can right now to help you." Moving ahead to the detailed explanation, this question centers on therapeutic communication during an acute crisis. A perforated ulcer is a surgical emergency that can quickly lead to peritonitis, sepsis, or shock, and the client's fear of dying is both realistic and deeply human. The nurse's primary responsibility extends beyond clinical care. It involves emotional support and reassurance that is truthful, compassionate, and grounded in presence. Option 1 is the most appropriate because it offers realistic reassurance while acknowledging that the healthcare team is taking immediate action. It neither minimizes the client's fear nor gives false hope. This response embodies therapeutic communication. It validates emotion, demonstrates empathy, and fosters trust, which helps stabilize the client psychologically during a medical crisis. In contrast, Option 2 is incorrect because referring the client's question to the physician avoids addressing the emotional need. Such avoidance can make the client feel dismissed and heighten their anxiety at a vulnerable moment. Option 3 is non-therapeutic, since labeling the question as silly invalidates the client's feelings, discouraging open expression. This approach damages rapport and may lead the client to withhold further fears or questions. Option 4, though seemingly comforting, is also incorrect because it represents false reassurance. Each case is unique, and implying a guaranteed positive outcome may later break trust if complications arise. Ultimately, therapeutic communication is the foundation of nursing care in emergencies. The nurse's calm tone, eye contact, and honest yet supportive words can transform a moment of panic into one of courage and cooperation. This aligns with the American Nurses Association (ANA) Code of Ethics, which emphasizes compassion, respect, and human dignity in all interactions. Transitioning now to the Stancoast clinical insight, honesty heals fear faster than empty promises. A nurse's calm words and genuine empathy can restore the client's strength to fight even in the face of uncertainty. And now, leading into our Stancoast high-yield NCLEX Pearl, always use therapeutic communication. Acknowledge fear and assure continuous care. Avoid false reassurance, blocking questions, or invalidating statements. In every crisis, the most healing words are those that are honest, compassionate, and grounded in presence. Remember this golden rule: empathy plus realism equals effective therapeutic response. Let us smoothly transition into this next question that explores an essential aspect of post-operative respiratory care. A client has undergone a gastrojejunostomy, also known as a Billroth 2 procedure, to treat a perforated peptic ulcer. Shortly after surgery, the nurse observes that the client hesitates to cough and take deep breaths because of incisional pain. In this case, which nursing action would be the most appropriate to promote effective airway clearance? Here are the options. The first option suggests explaining to the client about the high risk for developing pneumonia. The second option recommends instructing the client to splint the incision with a pillow while coughing. The third option advises requesting the physician to order supplemental oxygen for the client. The fourth option proposes keeping the head of the bed elevated at all times. The correct answer is Option 2. Instruct the client to splint the incision with a pillow while coughing. Now moving forward to the detailed rationale, after a gastrojejunostomy or Billroth 2 procedure, the primary postoperative concern is preventing respiratory complications, such as atelectasis and pneumonia. The location of the upper abdominal incision often causes significant pain with movement, coughing, or deep breathing. This discomfort discourages the client from taking full breaths, leading to shallow respirations and mucus retention, which can ultimately result in lung collapse or infection. Therefore, the nurse's priority is to ensure effective airway clearance while minimizing pain. Option 2 is correct because splinting the incision, by holding a pillow gently but firmly against the abdominal wound during coughing, provides physical support and reduces pain by stabilizing the muscles around the incision. This technique not only enhances the client's comfort, but also increases confidence in performing deep breathing exercises. As a result, lung expansion improves, retained secretions are expelled, and the risk of postoperative pneumonia and atelectasis is greatly reduced. Additionally, nurses should encourage the use of an incentive spirometer, early ambulation as tolerated, and administration of analgesics about 30 minutes before respiratory exercises to achieve optimal outcomes. In contrast, option 1 is incorrect because explaining the risk of pneumonia, although informative, does not address the actual barrier, pain, that prevents the client from coughing effectively. Education alone cannot substitute for direct physical support. Option 3 is also incorrect because requesting supplemental oxygen treats hypoxemia but does not solve the mechanical problem of poor ventilation caused by shallow breathing. Oxygen may be necessary later, but is not the immediate intervention. Option 4, keeping the head of the bed elevated, helps lung expansion but cannot replace active coughing and deep breathing. Without effective airway clearance, mucus still accumulates, putting the client at risk for respiratory complications. Transitioning to Stancoast Clinical Insight. After upper abdominal surgery, pain limits the client's willingness to breathe deeply or cough effectively. Splinting transforms fear into control, allowing the client to protect the incision, mobilize secretions, and breathe freely. The nurse's role is not only to prevent infection, but also to restore confidence in every breath. And now, leading into our Stancoast High-Yield NCLEX Pearl, splinting supports the incision, reduces pain, and enhances cough effectiveness. Encourage incentive spirometry every 1 to 2 hours postoperatively, and administer analgesics 30 minutes before coughing or ambulation. Preventive respiratory care involves deep breathing, coughing, early ambulation, and adequate pain control. Always remember, support plus pain relief equals clear airways. Before we begin the next NCLEX discussion, take note of an opportunity that could truly enhance your preparation.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Let us now move on to another thought-provoking NCLEX-style scenario that tests your understanding of postoperative care and fluid balance monitoring. Imagine you are caring for a client who has just undergone a gastrojejunostomy, also known as a Billroth 2 procedure. During your shift, you suddenly notice that the nasogastric tube, which had been draining normally, has now stopped functioning. Upon notifying the physician, you receive an order to irrigate the nasogastric tube. The question is, which technique should you, as the nurse, correctly use when performing this irrigation? Here are the options to consider. Option 1 suggests instilling 30 milliliters of sterile distilled water into the tube. Option 2 proposes administering oxygen before performing the irrigation. Option 3 recommends recording the exact volume of solution instilled and the amount withdrawn. Option 4 advises asking the client to swallow frequently during the procedure. The correct answer is Option 3, record the exact volume of solution instilled and the amount withdrawn. Now, let us carefully explore the expanded advanced rationale behind this answer. Following a gastrojejunostomy, it becomes crucial for the nurse to monitor intake and output with precision. Every milliliter counts, as even subtle changes can indicate post-operative complications such as leakage, obstruction, or electrolyte imbalance. When a nasogastric tube stops draining, it may be due to blockage from thick secretions or kinking in the tube. Before proceeding with irrigation, The nurse must first verify the tube's placement and ensure it is properly positioned to prevent accidental irrigation into a displaced or migrated tube, which could cause severe injury. During irrigation, the appropriate solution to use is normal saline, or 0.9% sodium chloride, rather than distilled or sterile water. This is because saline is isotonic, maintaining the delicate electrolyte balance of gastric tissues and preventing osmotic injury. Using distilled or sterile water, as mentioned in option 1, is unsafe since it is hypotonic and may lead to mucosal irritation or electrolyte disturbances, especially in the delicate postoperative period. The key nursing action emphasized in option 3, recording both the amount instilled and the amount withdrawn, ensures accurate fluid documentation. This precision helps the healthcare team identify whether the instilled solution is being returned as expected. If any discrepancy exists, such as less fluid being aspirated than instilled, it could point to an obstruction, leakage at the anastomotic site, or surgical disruption. In such cases, irrigation must be stopped immediately, and the surgeon must be notified, as continuing could worsen the complication. Meanwhile, option 2, which suggests administering oxygen, applies to suctioning or airway management, not nasogastric tube irrigation. Option 4, asking the client to swallow, would not help in this case since swallowing does not influence gastric tube patency, given that the nasogastric tube bypasses the oropharynx. Additionally, it is imperative never to use force during irrigation, as doing so can cause gastric rupture or damage to the newly constructed surgical site. As a vigilant nurse, continuous observation of the nasogastric drainage color, consistency, and volume also provides valuable insights into post-operative recovery. For example, coffee ground drainage may signal bleeding, while the absence of bile-colored output might suggest obstruction. Transitioning to the Stancoast clinical insight. Before we conclude, here's an important clinical reflection. Post-gastrojejunostomy care is all about precision. Recording every milliliter of fluid instilled and retrieved is not just documentation, it is the nurse's first line of defense against silent anastomotic leaks. And now, leading into our Stancoast high-yield NCLEX Pearl, remember these key takeaways for your NCLEX success. Always use normal saline for nasogastric tube irrigation, never distilled water. Document the exact amount instilled and withdrawn to ensure accurate intake and output tracking. Stop the procedure immediately if you feel resistance or if the client reports pain. And most importantly, if you notice unreturned irrigant or blood-tinged aspirate, notify the surgeon without delay. Let us move ahead to another clinically practical NCLEX-style question that challenges your ability to think critically about fluid balance and postoperative care. After the physician orders discontinuation of the nasogastric tube, a client recovering from gastrointestinal surgery is prescribed a full liquid diet. The nurse must now accurately record the client's total intake for the last 8 hours. The client consumed the following items: 1 cup of thin-cooked cereal, 1 8-ounce carton of milk, 1/4 cup of ice cream, 8 ounces of a nutritional supplement drink, 6 ounces of creamed soup, and 1/2 cup of fruit-flavored gelatin. Based on this information, how many milliliters of total fluid intake should the nurse record? Here are the options to consider. Option A, 980 milliliters. Option B, 1,020 milliliters. Option C, 1,080 milliliters. And option D, 1,140 milliliters. The correct answer is option C, 1,080 milliliters. Now, let us analyze the advanced rationale behind this calculation. Fluid intake includes not only the liquids a patient drinks directly, but also any foods that are liquid at room temperature, or become liquid once ingested. In clinical practice, this precise documentation is essential for assessing hydration status, renal function, and overall post-operative recovery. Every milliliter contributes to the body's fluid balance, which influences electrolyte stability and organ perfusion. Let us calculate the total step by step. 1 cup of thin-cooked cereal equals 240 milliliters. The 8-ounce carton of milk adds another 240 milliliters. 1/4 cup of ice cream contributes 60 milliliters. The 8-ounce nutritional supplement drink equals 240 milliliters. 6 ounces of creamed soup amount to 180 milliliters. Lastly, 1/2 cup of gelatin equals 120 milliliters. When all these are summed, 240 plus 240 plus 60 plus 240 plus 180 plus 120 The total fluid intake is 1,080 milliliters. This documentation is especially vital after nasogastric tube removal because it verifies the client's ability to tolerate oral fluids without complications such as nausea, vomiting, abdominal distension, or aspiration. Monitoring accurate intake and output, I&O, also helps correlate hydration adequacy with renal output, providing valuable data for clinical decision-making. Transitioning to another important consideration, remember that a full liquid diet includes all foods that are liquid at body temperature, such as milk, soups, gelatin, custards, and nutritional supplements. On the other hand, foods like mashed potatoes, pudding, or pureed fruits belong to the mechanical soft diet, not the full liquid category. Understanding these distinctions ensures safe dietary progression for post-operative clients. Transitioning to the Stancoast clinical insight, fluid balance is not just a number, it is a reflection of the body's internal harmony. Every milliliter documented by the nurse contributes to maintaining that equilibrium. In post-surgical clients, especially after nasogastric tube removal, this precision helps detect subtle signs of dehydration, fluid overload, or delayed gastric recovery. And now, leading into our Stancoast high-yield NCLEX Pearl. When calculating intake, always include foods that liquefy at body temperature. Memorize key conversions. 1 cup equals 240 milliliters and 1 ounce equals 30 milliliters. Keep strict I&O records for clients recovering from gastrointestinal surgeries, those with renal conditions, or those on fluid restrictions. Finally, always correlate intake with urine output, ensuring at least 30 milliliters per hour to verify adequate renal perfusion and hydration. Let us now transition smoothly into another essential question that tests your knowledge of post-gastrointestinal surgery complications and evidence-based client teaching. A nurse is developing a comprehensive teaching plan for a client who has developed dumping syndrome after undergoing a gastrojejunostomy, also known as a Billroth II procedure. The question asks, which of the following instructions should the nurse include to help the client prevent symptoms associated with dumping syndrome? Select all that apply. Here are the options. Option 1, consume a generous amount of fluid during meals. Option 2, avoid eating simple carbohydrates. Option 3, restrict consumption of raw fruits and vegetables. Option 4, eat several small meals throughout the day. Option 5, lie down for 30 minutes after a meal. Option 6, chew food thoroughly while eating. The correct answers are Option 2, avoid eating simple carbohydrates. Option 4, eat several small meals throughout the day. And Option 5, lie down for 30 minutes after a meal. Now, let us analyze this question in depth to understand the advanced rationale. Dumping syndrome develops when food empties too quickly from the stomach into the small intestine following gastric surgery, especially when the pyloric sphincter has been bypassed or removed. This rapid emptying allows hyperosmolar chyme to enter the small intestine, pulling large amounts of fluid from the bloodstream into the intestinal lumen. The result is abdominal cramping, diarrhea, dizziness, tachycardia, and hypotension occurring soon after eating. In addition, 1 to 3 hours later, the body reacts with an excessive insulin release, causing reactive hypoglycemia characterized by weakness, sweating, and confusion. Moving forward, let us evaluate each option individually. Beginning with Option 2, avoid eating simple carbohydrates. Correct. Simple sugars such as candy, pastries, syrups, and fruit juices are rapidly absorbed and exacerbate osmotic fluid shifts in the intestine, worsening early symptoms and leading to reactive hypoglycemia. Instead, the client should consume complex carbohydrates, proteins, and moderate fats to slow digestion and stabilize glucose levels. Next, focusing on Option 4, eat several small meals throughout the day. Correct. Frequent small meals reduce the volume of gastric contents entering the small intestine at once, thereby preventing sudden fluid shifts and maintaining steady postprandial glucose levels. This approach helps minimize both early and late dumping effects while supporting better nutrient absorption. Now, emphasizing Option 5, lie down for 30 minutes after a meal. Correct. Resting in a semi-recumbent or supine position slows gastric emptying and minimizes the gravitational effect that accelerates intestinal filling. This prevents post-meal hypotension and allows more time for nutrient absorption before the food passes rapidly through the intestine. Shifting focus to the incorrect options, Option 1, consume a generous amount of fluid during meals. Incorrect. This worsens the condition by increasing gastric volume and promoting rapid transit into the intestine. Clients should be advised to avoid drinking fluids 30 minutes before and after meals to slow gastric emptying. In addition, option 3, restrict consumption of raw fruits and vegetables. Incorrect. This restriction is unnecessary. These foods do not cause dumping syndrome unless they are poorly tolerated. The focus should remain on controlling carbohydrate type and timing of fluid intake. Lastly, option 6, chew food thoroughly while eating. Incorrect. While thorough chewing aids digestion, it does not directly prevent dumping syndrome. The critical preventive measures include eating small, frequent meals, avoiding simple sugars, and resting after eating. Transitioning to the Stancoast. Clinical insight: dumping syndrome is essentially a speed problem. Food races through the digestive tract too quickly, and the nurse's role is to teach the client how to slow the pace, encouraging small, well-balanced meals, avoidance of sugary foods, and resting after meals helps restore comfort, maintain blood glucose stability, and prevent circulatory collapse. And now, leading into our Stancoast high-yield NCLEX Pearl. Always separate solid food from fluids by 30 minutes. Replace simple sugars with complex carbohydrates and lean proteins. Eat 5 to 6 small meals throughout the day and lie down for half an hour after eating. Monitor for late dumping signs like dizziness, sweating, or weakness as indicators of hypoglycemia. Let us now dive into a clinically significant scenario that highlights the importance of diagnostic interpretation in oncology nursing. A 74-year-old client reports persistent indigestion, a sensation of gastric fullness even after small meals, and unexplained weight loss over the past 3 months. During the diagnostic evaluation, the nurse carefully reviews several test results to determine the underlying cause. The question arises: which finding would most strongly indicate that these symptoms are caused by gastric carcinoma, also known as stomach cancer? Here are the options to consider. Option 1 presents a gastric analysis showing an absence of hydrochloric acid. Option 2 lists an elevated gastrin level in the blood. Option 3 describes gastric irritation observed during gastroscopy. And option 4 notes a decrease in hemoglobin and hematocrit levels. After evaluating all options, the correct answer is option 1, gastric analysis showing absence of hydrochloric acid. Now, let us explore this concept in depth to understand the reasoning behind it. The absence of free hydrochloric acid, known as achlorhydria, in gastric secretions serves as a classical biochemical hallmark of advanced gastric carcinoma, particularly when the tumor involves the fundic or body mucosa. Normally, parietal cells within the gastric glands secrete hydrochloric acid that maintains a stomach pH between 1 and 3, supporting digestion and acting as a first line of defense against pathogens. However, when malignant transformation occurs, these healthy cells are replaced by fibrotic or atrophic tissues that lack secretory function. As a result, acid secretion diminishes drastically or disappears altogether, even when stimulated pharmacologically with histamine or pentagastrin. From a clinical standpoint, this absence of acid helps distinguish gastric cancer from conditions such as peptic ulcer disease, where acid production is usually normal or increased. Furthermore, the loss of both acid and intrinsic factor interferes with vitamin B12 absorption, which may lead to megaloblastic anemia, a condition that sometimes coexists with gastric malignancy. Therefore, when a nurse identifies achlorhydria on gastric analysis, it serves as a powerful biochemical clue that differentiates malignant disease from benign gastric irritation or simple dyspepsia. Transitioning now to option analysis, let us understand the reasoning behind each choice. Option 1, gastric analysis showing absence of hydrochloric acid, is correct. This finding is the most diagnostic laboratory indicator of gastric carcinoma. The infiltration of tumor cells destroys acid-secreting parietal cells, leading to achlorhydria or hypochlorhydria. It reflects structural mucosal damage associated with chronic atrophic gastritis, a known precancerous condition. Identifying achlorhydria in clients who present with unexplained fullness, persistent indigestion, and weight loss should prompt urgent oncologic evaluation. On the other hand, option 2, elevated gastrin level in the blood, is incorrect. Elevated gastrin is characteristic of Zollinger-Ellison syndrome, not gastric carcinoma. In gastrinoma, a gastrin-secreting tumor triggers hyperacidity and recurrent peptic ulcers, which are quite the opposite of achlorhydria found in gastric cancer. Moving to option 3, gastric irritation noted during gastroscopy, this too is incorrect. Although erythema or irritation may appear during endoscopy, it is nonspecific and often results from gastritis, medication effects such as nonsteroidal anti-inflammatory drug use, or Helicobacter pylori infection. True malignancy usually presents as ulcerated, nodular, or infiltrative lesions, not mere irritation. Finally, option 4, decrease in hemoglobin and hematocrit, is also incorrect. While anemia often accompanies gastric cancer due to chronic bleeding or nutritional deficiency, it lacks diagnostic specificity because many gastrointestinal conditions can produce the same finding. Thus, although supportive, it cannot confirm malignancy without other evidence. Now, before we conclude, let us connect this knowledge with a deeper clinical perspective through our Stancoast clinical insight. Gastric carcinoma often develops silently, but it leaves behind biochemical footprints long before structural changes appear. Achlorhydria acts as that silent warning sign, a biochemical red flag signaling that normal gastric physiology has been replaced by malignant transformation. And to summarize everything in a quick review, here comes your Stancoast high-yield NCLEX pearl. Remember this simple correlation. Absence of hydrochloric acid points toward gastric carcinoma. Increased gastrin levels indicate Zollinger-Ellison syndrome. Gastric irritation implies nonspecific inflammation rather than malignancy. And anemia serves only as a supportive, not diagnostic, finding. Ultimately, early detection through gastric analysis and endoscopy is crucial, as gastric cancer often presents subtly with signs like early satiety, indigestion, and weight loss. Let us shift our focus to another crucial post-operative nursing scenario that tests both knowledge and judgment. The client has been diagnosed with stomach cancer and has undergone a total gastrectomy. Following surgery, the client has a single-lumen nasogastric tube in place for gastric decompression. During recovery, the client tells the nurse, "I am extremely thirsty." The question is, in response to this concern, which nursing intervention would be most appropriate to add to the care plan? Here are the options to consider. Option 1 suggests offering fluids at least every 2 hours. Option 2 recommends providing crushed ice in sparse amounts. Option 3 advises increasing oral liquids on the dietary tray. Option 4 proposes refilling the water pitcher twice each shift. After analyzing all options carefully, the correct answer is Option 2. Provide crushed ice in sparse amounts. Now, moving on to the expanded rationale, so that we understand the reasoning behind this decision. After a total gastrectomy, the client's stomach has been completely removed, meaning the gastrointestinal tract needs time to heal and adapt before any oral intake can safely resume. A single-lumen nasogastric tube is inserted during surgery to continuously remove gastric secretions, prevent distension, and protect the suture line at the esophageal jejunal anastomosis. Since the nasogastric tube is connected to low continuous suction, any fluids introduced orally would be immediately withdrawn through suction, leading to significant loss of electrolytes and a high risk of metabolic imbalances, such as hyponatremia or hypokalemia. At this stage, the client remains strictly on nothing by mouth status until bowel sounds return and the surgeon confirms readiness for oral intake. However, post-operative thirst can cause major discomfort, and this is where nursing judgment becomes crucial. Providing small, controlled amounts of crushed ice offers oral moisture and comfort without introducing a large fluid load into the gastrointestinal tract. The ice melts slowly, moistening the mouth and lips, reducing dryness, and easing discomfort, without interfering with suction function or healing. If the nurse were to provide larger fluid volumes, as suggested in options 1, 3, or 4, the water would quickly accumulate and be suctioned back out through the nasogastric tube. This not only leads to electrolyte depletion, but also delays healing and increases the risk of pressure on the suture line, potentially resulting in anastomotic leakage, a serious, life-threatening complication. Furthermore, excess oral fluid could trigger nausea, vomiting, or abdominal distension, all of which compromise recovery. Hence, the safest and most appropriate intervention is to provide crushed ice sparingly, while ensuring comfort, surgical safety, and electrolyte stability. Along with this, nurses should perform frequent oral care, using swabs moistened with sterile water or normal saline to reduce dryness, maintain mucosal integrity, and prevent infection. Transitioning now to the Stancoast Clinical Insight, here is an essential reflection for practice. After total gastrectomy, the stomach's protective and reservoir functions are lost. The nasogastric tube serves as the bridge that safeguards the healing site while maintaining decompression. The art of nursing lies in balancing comfort with safety, offering only what soothes without sabotaging recovery. Finally, as we move to the Stancoast High-Yield NCLEX Pearl, remember these vital takeaways for your exam and clinical practice. Clients with nasogastric tubes after gastrectomy remain strictly on nothing-by-mouth status until peristalsis returns. Do not irrigate, reposition, or remove the nasogastric tube without a surgeon's explicit order. Crushed ice or saline swabs may be used for oral comfort only. Always monitor for hypovolemia, electrolyte imbalance, and the characteristics of nasogastric drainage. A clear liquid diet is introduced only after the surgeon's approval and once bowel sounds are confirmed to have returned.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Let us transition smoothly into this NCLEX-style dosage calculation question that blends pharmacology, math precision, and clinical reasoning. 1 year after undergoing a total gastrectomy, a client develops pernicious anemia as a result of loss of intrinsic factor and decreased absorption of vitamin B12 from the gastrointestinal tract. The home health nurse is scheduled to administer 1,000 micrograms of vitamin B12 intramuscularly every month. The label on the medication vial reads, vitamin B12, 1 milligram per milliliter of solution. So the critical question is, how many milliliters should the nurse accurately withdraw for administration? Here are the options for careful consideration. Option 1, 0.1 milliliter. Option 2, 1 milliliter. Option 3, 10 milliliters. Option 4, 0.01 milliliter. After analyzing the data, the correct answer is option 2, 1 milliliter. Now moving thoughtfully into the expanded rationale. After a total gastrectomy, the stomach's parietal cells, which normally secrete intrinsic factor, are removed. Without intrinsic factor, vitamin B12 cannot bind in the small intestine for absorption, leading to pernicious anemia, a megaloblastic anemia that manifests with fatigue, pallor, glossitis, and even neurologic symptoms such as paresthesias and gait disturbances. Because this absorption pathway is permanently disrupted, vitamin B12 must be given parenterally, that is, intramuscularly or deeply subcutaneously, to bypass the gastrointestinal tract and achieve proper systemic absorption. Next, let us apply a precise dosage calculation. The vial label indicates a concentration of 1 milligram per milliliter, and since 1 milligram equals 1,000 micrograms, the available dose is exactly 1,000 micrograms per milliliter. The provider's order is for 1,000 micrograms. Therefore, the nurse must withdraw 1 milliliter of the solution. This precise measurement ensures the client receives the prescribed amount required to correct the anemia and prevent irreversible neurologic injury. It also underscores a vital nursing principle. Always confirm unit conversions before administering medication to avoid under- or overdosing. From a clinical practice perspective, the nurse must verify the provider's order, check the vial concentration, and confirm the correct route prior to giving the injection. Using a 1 milliliter syringe promotes accuracy. The medication should be injected into a large muscle, such as the deltoid or ventrogluteal site. Post-administration, continuous monitoring of hematologic recovery, including hemoglobin, hematocrit, and reticulocyte count, is essential. The nurse must also educate the client that vitamin B12 replacement is lifelong after a gastrectomy, since the absence of intrinsic factor is permanent. Consistent monthly therapy prevents recurrence of anemia and maintains neurologic health. Transitioning to a Stancoast clinical insight. Total gastrectomy permanently eliminates intrinsic factor production. Monthly vitamin B12 injections are not optional. They are the client's lifeline, protecting against megaloblastic anemia and irreversible nerve damage. Now moving on to the Stancoast high-yield NCLEX Pearl, always confirm that 1 milligram equals 1,000 micrograms before performing any dosage calculation. In pernicious anemia, vitamin B12 therapy must be lifelong and intramuscular. Clients typically notice improvement in fatigue and pallor within weeks, while neurologic recovery can take several months. Continuous follow-up with periodic complete blood count monitoring and strong patient education on adherence are essential for long-term success. Let us now transition into this advanced NCLEX-style scenario that highlights both anatomical precision and safe medication practice. A nurse is preparing to administer a prescribed intramuscular injection of vitamin B12 to a client diagnosed with pernicious anemia, and the vastus lateralis muscle is chosen as the preferred site. The critical question arises: if the correct technique is followed, in which location and at what angle should the nurse administer this injection? Here are the options to analyze carefully. Option 1, upper arm at a 45-degree angle. Option 2, outer thigh at a 90-degree angle. Option 3, anterior thigh at a 90-degree angle. Option 4, outer buttock at a 45-degree angle. After applying sound clinical reasoning, the correct answer is option 2, outer thigh at a 90-degree angle. Continuing forward into the in-depth rationale, the vastus lateralis muscle, located on the outer aspect of the thigh, is one of the safest and most preferred sites for intramuscular injections. It is large, well-developed, and positioned away from major nerves and blood vessels, which makes it a reliable site for both adult and pediatric clients. The injection must be given at a 90-degree angle to ensure that the medication reaches the muscle tissue for optimal absorption. To find the correct area, the nurse divides the thigh into 3 equal parts between the greater trochanter and the lateral femoral condyle, selecting the middle third on the outer side as the injection zone. Now, diving deeper into the physiological reasoning, clients with pernicious anemia lack intrinsic factor, a glycoprotein produced by the gastric mucosa that is essential for the absorption of vitamin B12 in the intestines. Without this factor, dietary vitamin B12 cannot be absorbed, resulting in megaloblastic anemia and neurological complications. Administering vitamin B12 intramuscularly bypasses the gastrointestinal tract and ensures effective absorption directly into the bloodstream. Following the injection, gentle pressure may be applied, but vigorous massage should be avoided to prevent irritation and bruising. Let us also explore why the other options are not appropriate, starting with option 1, upper arm at 45 degrees. This corresponds to the deltoid muscle, which is not suitable for larger medication volumes, such as 1 milliliter of vitamin B12, and the angle of 45 degrees is incorrect for intramuscular administration. Moving to option 3, anterior thigh at 90 degrees, this targets the rectus femoris muscle, which can cause greater discomfort and a higher risk of nerve injury, making it a less preferred site. Finally, option 4, outer buttock at 45 degrees. This describes the dorsogluteal site, which is no longer recommended due to its proximity to the sciatic nerve and unpredictable fat thickness that can lead to inconsistent absorption. Transitioning into a clinical perspective, correct anatomical identification and injection technique are critical to preventing complications such as pain, hematoma, or nerve injury. Nurses must always prioritize safety and precision to ensure therapeutic effectiveness. Now, moving into the Stancoast clinical insight. The vastus lateralis site combines both safety and reliability, the perfect balance for intramuscular vitamin B12 therapy. By maintaining a 90-degree angle and targeting the mid-outer thigh, the nurse ensures proper absorption while minimizing the risk of nerve or vascular injury. Finally, here comes the Stancoast high-yield NCLEX Pearl. Always use the outer middle third of the thigh for vastus lateralis injections. Maintain a 90-degree angle to reach muscle tissue effectively. Rotate injection sites for long-term vitamin B12 therapy. Avoid dorsogluteal injections to prevent sciatic nerve injury. Thanks for watching. We will be there very soon with new topics.